Okay, this few slides is on management of blood cholesterol. I wanted to give you a bit more relevant and important and updated information on management of cholesterol and the use of statins and other drugs. In 2013, we went from the ATP guidelines, which really emphasized um, levels of LDL and targeting LDL specifically and um, getting patients to a certain goal based on their risk factors. We've moved away from that with these new guidelines, or newer guidelines, I should say, from the American College of Cardiology and American Heart Association. So basically, we have 4 risk categories. So this is a way of stratifying risk. So basically, 4 patient groups that are thought to benefit from a statin. The first group, and the first group are patients over the age of 21 who have known ASCVD. So they've had a heart attack. There is known coronary blockages, for example. Those people should be on a statin. Then patients who have an LDL of greater than 190 are thought to be in a higher risk group. Those people should be on a statin. Patients with diabetes between the age of 40 and 75, when they get to that age, they have diabetes, need to be on a statin. And then everybody else in ages 4 to 75 years who don't have heart disease, don't have diabetes, don't fall into that category of greater than 190 LDL, those people are put into a risk calculator. And we determine what their 10-year risk is for having a heart attack or stroke, for example. So if their ASCVD risk is greater than 7.5 or above, they are thought to be in a high enough risk to be on a statin. So those are the people we target for primary prevention. So some things that we do need to consider, of course, with any patient is, are they going to stay on it? Patients hear a lot from friends of theirs who've taken statins and have had the muscle aches or other side effects and may be very resistant to go on a statin. So you may try lifestyle changes for a while. If you do put them on a statin, are they going to tolerate it? And in what dose are they going to tolerate it? Sometimes it's important to start with very low doses just to get the patient on board. There are other interventions that should be considered besides statins, and I'll talk a little bit about those, but those can also be considered in patients that are really high risk that can be added to a statin. So what do we mean by risk? How do we get the ASCVD risk score? There is a calculator that can be used that you can use online. It's usually available on most of the EMR systems. It's a cardiovascular pooled cohort risk assessment. And these are the factors that it takes into account. So what the age or sex of the patient is, whether they're Black or anything else, white or anything else, total cholesterol, HDL cholesterol, their systolic blood pressure, and are they treated for hypertension? Are they a smoker, and do they have diabetes? So this is what it can actually look like. If you go to an online site, you can just put cardiovascular pooled cohort risk into your browser, and this is one of the calculators you can get. And the neat thing about this is that it's interactive. You can do it right in front of the patient. And you can make changes. You can make them 5 years older. You can make them no longer a smoker. You can lower cholesterol to see if that is something that can be achieved. If they need to lose weight, they may be on an antihypertensive for their blood pressure, and if they lose weight, they may stop their drugs. So this is kind of a neat tool to use with patients so that they can pretty much see what the prognosis is for their cholesterol management. So this slide shows how to approach primary prevention for ASCVD. This slide shows you what we mean by high intensity versus moderate intensity versus low intensity statins. So basically, the only two that fit into the high intensity because of their potency are atorvastatin or Lipitor and rosuvastatin or Crestor. And the high intensity doses are the higher doses, atorvastatin 40 to 80 and rosuvastatin 20 to 40. And then you can see what moderate intensity, same drugs, lower doses, and other lower potency statins that will fit into the moderate and low intensity treatment. This slide shows the decision guidelines for secondary prevention or patients diagnosed with ASCVD. And as you can see, high intensity therapy is recommended for all patients using a goal of less than 70. And there are age factors. So you may use moderate intensity depending on the age, but you also may use other drugs. So if a patient is at higher risk, consideration should be given to the use of ezetimibe, which is Zetia, which can be added to a statin. And then consideration could be given for the PCSK9 inhibitors, such as Repatha. That can also be added. So just a few words about these non-statins. Zetia came out some years ago and was not really found to be all that useful in studies at that point. Simvastatin also is not the most potent statin, but Vytorin is a combination of Zetia and simvastatin. And the drug companies for these drugs were pretty happy to find that the Improve It trial, which randomized patients who experienced a recent acute coronary syndrome event to Zetia plus a moderate intensity simvastatin, basically Vytorin, at 40 milligrams, or they used a placebo plus simvastatin, and those patients had much better outcomes. So most of the benefit came from a reduction in non-fatal MIs. So they still had some events, but there was a significant difference in death from MIs in patients that were either on the Zetia, well, actually in this trial, it was Vytorin, the combination of simvastatin and Zetia. So kind of interesting, once again, we have monoclonal antibodies, the PCSK9 inhibitors. They actually work differently from the statins, but they actually promote the modulation of the receptor that clears LDL cholesterol. So when you give the drug, you actually prolong the receptor life and clear more cholesterol. And they're given as injectables, one injection every 2 to 4 weeks. So we have at our disposal, well, you would have it at your disposal if you're working in really in a specialty clinic, Repatha and Praluent. These are not something that are used in primary care. They're not something that are going to be initiated in the hospital setting in an acute situation. But patients that are very high risk, these may be considered. So this slide shows pretty much the summary of recommendations for practice. As I said previously, a patient with high-risk ASCVD who has a 10-year risk of at least 7.5 should be on a statin. We should use statins for secondary prevention in patients with known ASCVD unless they're contraindicated. Niacin, fibrates, omega-3 fatty acids really don't have a big role. They might lower cholesterol levels and we might use them, but they're really not going to affect patient outcomes. There really haven't been studies showing that they impact outcomes for patients, and these have been consistent results in meta-analyses and systematic reviews. And then finally, a moderate intensity statin plus Zetia could be considered as an alternative in patients with acute coronary syndrome. if they can't tolerate the high dose statin therapy. So generally we use Lipitor 80 or Crestor 40 when patients are hospitalized with acute coronary syndrome. We send them home with these high dose statins. But if they can't tolerate them, we can also, there's actually a place for Zetia. And when it first came out, it was used, but it took a while for real changes in outcome to come to light. And now it is actually part of the recommendations.